Maurice Strauss Distinguished Public Lecture Series. Before I have the pleasure of introducing today's speaker, I want to put in a plug, as I always do, for the next upcoming talk. So the next presentation will actually be next Thursday. We normally don't have two back-to-back, but due to scheduling, that's how it turned out. And next Thursday, same time, same station, Dr. John Halamka will be here. Dr. Halamka is professor of medicine at Harvard Medical School. He's the Chief Information Officer of Beth Israel Deaconess Medical Center and chairman of the New England Healthcare Exchange Network. And he'll be talking to us about what's next in digital healthcare. I think everybody knows that's a big and hot topic these days in healthcare, so it should be very interesting. So without further ado, it is my pleasure to introduce this evening's speaker, Dr. Ophira Ginsburg. Dr. Ginsburg is the director of the High-Risk Cancer Genetics Program at the Perlmutter Cancer Center at New York University Langone Health. She's also a faculty member and associate professor in the section for Global Health in the Division of Health and Health Behavior in the Department of Population Health at the NYU School of Medicine. Dr. Ginsburg did her initial training and undergraduate work in biology at Queen's University in Canada. She did her master's degree in human genetics at McGill University, and then went on to do her doctoral degree back at Queen's University as well. She completed her residency in internal medicine and medical oncology at the University of Toronto. And then she also did a postdoctoral fellowship and additional training in epidemiology and biostatistics at the Princess Margaret Cancer Center, Campbell Family Institute for Cancer Research. She was invited to join the faculty at the University of Toronto, where she has been a faculty member, and she also serves in a variety of other positions, including holding an academic faculty appointment in the Cancer Policy Institute at King's College in the United Kingdom. Dr. Ginsburg is extremely well known for her work as a leading internationally recognized expert on disparities in health and how to improve cancer survival rates, particularly for women. She has included in her work how social determinants and social inequalities disproportionately affect the world's most disadvantaged groups, leading to barriers to diagnosis and treatment and subsequently higher rates of cancer mortality. She is a practicing physician, hematologist, oncologist, works out of NYU and Bellevue Medical Center in New York. She's provided a number of important new insights through her research on how to significantly reduce global, regional, and within-country inequities in access to cancer care using strategies that link evidence-based public health policies to clinical outcomes. In particular, cervical cancer has been something that's been a focus of hers, and I think it epitomizes the disparities that she addresses. Of over 500,000 women diagnosed each year with this disease, 90% of these deaths occur in low and middle-income countries. Dr. Ginsburg has served on the World Health Organization's medical officer for cancer control in Geneva, Switzerland, spent about a year and a half or so there at WHO, and I've already learned a great deal about WHO and how it works and how much money it doesn't have, talking to her today. And she's helped build policies and programs there that frameworks for breast cancer prevention in collaboration with the World Health Organization International Agency on Research on Cancer and with other United Nations organizations. She's received numerous awards. She's a fellow of Canada's Royal College of Physicians and Surgeons. She's a recipient of the Queen's University Henry Kaufman Memorial Prize, the Queen's University Michael Brown Memorial Award in Oncology, and the Grand Challenges Canada Rising Stars for Global Health Award. She served as an advisor to the National Institutes for Cancer Control in Vietnam. She's a member of the Global Task Force on Radiotherapy for Cancer Control and the Technical Advisory Committee of the Global Task Force on Expanded Access to Cancer Care and Control. She serves on a number of editorial boards. She's been a founding editor of Journal of Cancer Policy and the Journal of Global Oncology, where she serves as associate editor right now. So please join me in welcoming our speaker this evening. I look forward to a great talk.
Thank you so much. I just dropped a battery. First of all, I sound busier than I probably am, but I want to first of all thank the Maurice Strauss family for this honor to speak with you today, and also to Professor Friedlander and the other colleagues I've already had the pleasure to meet. It's really, it's quite an institution here, and I've already had tremendous scientific discussions and learned a lot today. So the topic is social inequality in cancer survival. How do we close the gap? I think a lot of what I'm going to say is a bit of motherhood and apple pie, but hopefully putting it together in a way that gets us all thinking and perhaps talking in the Q&A. Okay, so advancing the slides doesn't seem to be working. There we go. Thank you. So I have no financial relationships to disclose, and sometimes I take this moment to say I have one disclosure, though, and that is that I am, in fact, Canadian. The reason I say this is because it actually, growing up in a universal health care kind of framework and system, informs how I view health as a human right, and I'm sure many people here, and probably all of you in this room, agree with that. My new disclaimer is that I have strong opinions, but my strong opinions are not driven by any financial interests or similar conflicts, rather than just for a passion for science, like many people here, and for social justice. So how many people here know who this is? Aha, quite a few. This is the great, unfortunately late, Professor Hans Rosling. Hans Rosling produced some incredibly important works, including his visualizations to help people from all walks of life and all countries understand how far we've actually come to reduce poverty, to improve the lives and livelihoods of men, women, and children worldwide, et cetera. And there's one quote from the last book that he published, Factfulness, in 2018, that I think is really relevant now more than ever, especially as I'm hearing that this is a post-truth world. And I don't believe that, and I'm sure you don't either. So factfulness is recognizing that a single perspective can limit our imaginations. And it's important to remember that it's better to look at problems from many angles to get a more accurate understanding and find practical solutions, right? So to control that urge we have, the single perspective instinct, he says, get a toolbox, not a hammer. And I think that's very relevant to the topic that I'm going to speak about. So cancer by the numbers. According to the World Health Organization's specialized agency for cancer called IARC, or the International Agency for Research on Cancer in Lyon, these are the latest data for global estimates of cancer incidence and mortality in 185 countries. This is really the source that we go to for the most accurate and up-to-date figures and also projections into the future. There's a lot of comparisons that can be made. This is an online resource. It's a fantastic portal, especially for students. You can build your own graphs and maps, etc. But the sad truth is, in 2018, there were 18 million new cases of cancer, and 9.6 million people died of cancer. That's about 1 in 5 men and 1 in 6 women who will develop cancer, 1 in 8 men and 1 in 11 million women will die. This is expected to increase 70% in the next 20 years. And the truth is, most of the people dying of cancer are in Asia, Africa, Latin America, and in the low-income and middle-income regions of the world. And when I say the income regions, I'm speaking of World Bank definitions according to gross domestic product. So why are cancer rates increasing? A lot of this is going to be probably well known to many of you. Population growth and aging. Now, the good news story there is that many and most countries, as the great Professor Rosling would tell us, people are moving out of poverty at a rapid pace now. Countries like China and India, there's been tremendous progress. A lot of efforts with the Millennium Development Goals have shown what the world can do when we come together, and what countries can do also to encourage each other and to see from setting these examples for each other what can be achieved to reduce maternal mortality, to improve the odds that a child will live to their 5th birthday and beyond, etc. And as we see the life expectancy increasing in most countries now, notwithstanding periods of time where HIV/AIDS was really ravaging parts of sub-Saharan Africa in particular and regions of conflict, we see this improving over time in almost all countries. And with that comes, right, cancer is a disease primarily of aging. So we do see more cancer just because of these demographic shifts. Lifestyles. I put lifestyles in quotation marks for a reason, so I don't forget to mention, right, tobacco, alcohol, our dietary choices, sedentary lifestyles, overweight and obesity are rapidly overtaking and causing the causes of non-communicable diseases in most countries now. But these so-called lifestyle diseases have another dimension which is often not referred to, but I prefer to call it, as the WHO does, the commercial determinants of health. So thinking about trade policy, thinking about efforts for marketing and finding new markets in countries that didn't have the means to purchase sugary beverages, et cetera, increasing alcohol intake and opportunities to become overweight and obese. These are extremely important. Infections such as hepatitis B, which is a major cause of liver cancer, human papillomavirus, which causes, as I'm sure you all know, cervical cancer, but also cancers of the head and neck, the anal cancer and vaginal and other cancers, penile cancer. H. pylori, which causes stomach cancer, and HIV as a risk factor for many cancers. In fact, infections cause about 25% of cancers, or are associated with 25% in cancers in low and middle income countries. And in some countries, particularly in sub-Saharan Africa, where HIV is still a huge issue, it's not solved yet, even with lots of good treatment available and even free treatment, we still see that infections contribute to about a third of all cancers in some of these countries. Add to that occupational other exposures, UV, et cetera, and you see why rates are increasing in many places. This is a photo I took in Hanoi, Vietnam in 2014. It's right around the corner from the old campus of the National Cancer Institute, where I've had the pleasure to spend quite a bit of time over about, since 2004. You can see here in the foreground that this lady is the only one left on a bike. She's also the only one wearing a conical hat, which is traditional. And the look on her face I thought was quite priceless as I took that photo. She's looking right at me saying, oh, yeah. Right? And so what you see here are a lot of people on bikes, motorcycles. Some of them have masks because air pollution is a huge problem in many countries, including Vietnam. And you see that sedentary lifestyles and lifestyles of more affluence with opportunities for those other exposures and commercial determinants of health is quite evident. And in fact, 30 to 50% of all cancer is preventable. Now, 20% of cancer deaths are due just to tobacco, not just smoking, but also smokeless tobacco, which is a huge cause of oral cancer, a terrible cancer in South and Southeast Asia, particularly in other parts of the world. So I'm going to show you some maps, and just to get a sense of what we're looking at here, this is the ranking of cancer as a cause of premature mortality. Premature mortality can be defined in different ways. I don't think this is working. Premature mortality is basically deaths before the age of 70. And you can see here that in North America, and here's my country, Canada, you see that cancer ranks as first. So cancer is more common in higher income countries, but it's becoming much more common and quickly rising in developing countries. Thank you. In fact, second most common cause of death, premature death, you can see, is taking over large other parts of the world. And even in sub-Saharan Africa, we see it still ranks among the top 10 causes of death now. Okay. P.S. though, North America, part of this is a good news story because it's due to partly the fact that cardiovascular disease and stroke are better controlled now, that cancer has now overtaken cardiovascular disease as a major cause of premature mortality. The next one I'm going to show you is a map indicating the Human Development Index. How many people here have heard of this? HDI. So quite a few. So the Human Development Index is a composite measure according to the UNDP development program that includes GDP per capita, life expectancy, and the highest level of education attained. And IARC actually uses the 4 tiers of the Human Development Index to look at how cancer rates and different types of cancer track with changes, mostly improvements, in the Human Development Index. Now, what do you see the same between the map I showed you before and the map you see now? Right. So it's quite clear when you see it visually what we're looking at. And in fact, the Cancer Transition was a seminal paper by Freddie Bray and his colleagues at IARC that indicated, how you can predict the patterns that the kinds of cancer people will develop in different countries according to improvements in the Human Development Index. But some things came out by looking at cancer trends according to the HDI that were surprising. For example, these girls and young women face greater cancer risks than their mothers and grandmothers did. And one would think that's mostly going to be breast cancer. Breast cancer is the #1 cancer in women in most countries. I'll show you more about that in a moment. But in fact, in many countries of the world that are going through positive changes in economic growth, but of course, economic growth by GDP doesn't always reflect what's happening in terms of the income inequality, and that's a whole other issue which we could talk about all day, and I'm sure there's more expertise here than what I have. But what I want to say here is that there's a number of countries, particularly in the former Soviet republics, where breast cancer is increasing rapidly, but cervical cancer, which the Human Development Index would expect would be decreasing due to improvements in the health system with screening, with treatment of precancers and opportunities to prevent, well, now with vaccination, et cetera. And yet you see both those cancers rising in many countries. Here you see breast cancer. This is the incidence worldwide. The incidence of breast cancer being the highest in high-income countries, and you can see that it's the pinking of the world, really, and there's only a handful of countries where you see the orange. And the orange represents cervical cancer. Cervical cancer is actually only the 4th most common cancer in women worldwide. Do you know what number it ranks here in the US? Actually, I forget the actual number, but it's not even in the top 10. Okay, cervical cancer has been largely reduced to near elimination. We'll talk about elimination towards the end, because of effective health systems that have supported population-based screening and access to highly effective and cost-effective treatment of precancers. Now we add to that vaccination of girls and boys, and we see where things are going. Well, look what happens when we look at mortality from cancer in women. Okay, so up here we have blue. The blue is lung cancer. So that's bad news and good news. The bad news is lung cancer is still highly deadly if you develop it. The bad news also is that women were still smoking so much, until a couple of decades ago, things started to change, largely due to policy initiatives, where we see still, we haven't quite reached, I think we're now reaching the peak of lung cancer in women. In men, it's been declining more quickly, actually. But we also see here the impact of good quality early detection and treatment for breast cancer. So breast cancer today in this country is largely curable. If you develop breast cancer in North America, you're very likely to survive your disease. The opposite is the case in most low and middle income countries. Anyway, one thing I want to draw your attention to here in sub-Saharan Africa, cervical cancer is the #1 cause of cancer-related death still in 42 countries, mostly in this particular region. Okay? This is entirely preventable. And in fact, cervical cancer is one of the top causes of mortality among women of reproductive age in some of these countries. So I'm giving you the bad news first. So if you live in a lower middle income country and you develop breast, cervical, colorectal cancer, whether you're male or female, cancers that we understand the natural history for which we know how to prevent and detect early, we have highly effective treatments. The prevention is considered very cost effective, or what WHO calls a best buy, okay? You're far less likely to survive your cancer if you're living in one of these countries versus a high-income country. And I think that, this point is well made now. Now I'm going to draw our attention now to the concepts of equity and equality. And I know probably everybody here in the room have seen these versions of these cartoons. Either it's a bunch of kids trying to see the baseball game, but I'm not a big fan of baseball, so now I prefer this one, where they're reaching for a fruit, reaching for an apple. And you can see here that equality, everyone here has the same size box to help them reach that apple. But 2 of the 3 still can't reach it. And here we have equity when the boxes have been adjusted to overcome those differences and ensure that everyone has a chance to have the apple. The National Cancer Institute actually defines health disparities, a particular type of health difference closely linked with social or economic disadvantage, right? And health disparities adversely affect groups of people who've systematically experienced greater social or economic obstacles to health, et cetera, et cetera. And this can be based on religion, socioeconomic status, gender, age. I'd say add to that gender identity. There's many other factors, and race and ethnicity, physical disability. And health equity, on the other hand, is the attainment of the highest level of health for all people. So really, that's the goal. So a number of us put together a series in the journal The Lancet a few years ago, where I led this initiative. We ended up with 3 papers with 40 authors, more than 40 authors from about 18 countries. And we wanted to have equity in the authorship, so half were women, and half of the authors were themselves from low or middle income countries. So we hopefully captured a broad range of voices. There were also cancer survivors among the authorship, policymakers. We had leads from the World Bank, World Health Organization contributions, and the National Cancer Institute here in the US, editorials and commentaries. I'm mentioning this because the commentaries were very interesting and worth looking at. This is open access. One was written by Otis Brawley, who I'm going to refer to later, who was at the time the Chief Medical Officer of the American Cancer Society, and Ambassador Sally Cole. I know it doesn't really show up well there. This one here, Women, Power, and the Cancer Divide, was by former... Very, very interesting. We were so delighted to have a female head of state in a country that had made great strides in fighting women's cancers. And she now, as you know, is the UN Commissioner for Human Rights. So the three papers, just to say briefly, one was about the burden, a lot of what we just talked about. The second one looked at interventions to close the divide. And the burden and the interventions papers also included information about high-income countries, which was a bit of a challenge. You know, people said, well, you're talking about global health, so that includes, right, global health. That's about developing countries. No, no, no. We are global. Global health includes all of us. And so we made a point of highlighting, including in my own country, that there are still great disparities in access to health services, and these are reflected in differences in cancer incidence in some cases, like cervical cancer, and cancer mortality, which is an issue among our own Indigenous communities in Canada and people living in rural areas. We've got a massive country, and most of the tertiary care facilities and the healthcare providers who are specialists are living oddly close to the US border, right? So in that band along the border. So the third paper was about policy, and this is really what I want to focus on for most of the rest of the talk. The main messages were the following. Where a woman lives, her socioeconomic, ethnocultural, or migration status should no longer mean the difference between life and death from these common cancers for which effective and cost-effective interventions exist. Actions, we said, actions need to mitigate these cultural and social attitudes. So also reminding ourselves that even if everything else was equal, and in Canada we have universal health coverage, I come back to this. So why do we have disparities if everybody has access to free health care? Well, because there's other factors that are going to play a role in whether or not somebody chooses to go for prevention services or even has that choice. Choice is a main topic here, right? I had a great discussion with a few people today among your faculty regarding the concept of choice. And when I worked in Bangladesh, we co-founded a breast clinic, and we were a little surprised that women, free clinic, and women were not coming very much. And when they did come, they had, I'm not going to show you a photo, but they had large, what's called fungating masses on their breast, something you see very rarely here, really bad, locally advanced breast cancer. And you might ask, why didn't she come sooner? Well, we asked them, how long did you know you had a problem? And why didn't you come sooner? So first of all, one thing I learned from a few mentors over the years is that poor women are poor. They're not stupid. These women knew they had a problem. They knew it was serious. They knew it could kill them. And they didn't come because they felt they had no choice. There's a short documentary, actually, that my colleagues produced in Bangladesh called A Choice, which was in their own words about the various complex interplay of factors that prevented them from coming for care earlier or presenting for care. And I hear this a lot. I just came back from Mozambique, African Organization for Research and Training in Cancer, big meetings every 2 years in a different African country. And I was in Tanzania a month before that. And I hear this a lot. Please stop saying that women don't present early. They're not diagnosed early. They may present early, but then they're turned away. So that's something we also have to work on. Healthcare provider education, including the first level of care, which might be a nurse or other healthcare provider, not necessarily a physician, certainly not a specialist or a primary care doctor like we have here in the US. They're told, no, it's probably an infection, it's nothing. Or they might go to a traditional healer because that's culturally appropriate, and then they're sent away. And then a year later, they come with the fungating mass, or they die at home, undiagnosed. So we have to also pay attention to the gender perspective and the role of decision-making. Who is the locus of decision-making for you? Well, for me, it's me. That's not the same for everyone. For some people, it's their mother-in-law, and it's their husband, right? So the engagement from political health leaders, civil society, and global health funders all play a role. So the question today for you all is, what does the global cancer divide have to do with me? I don't think I really need to ask this here, but you'd be surprised how many times I've been asked, why are you going off to Bangladesh when we have healthcare disparities here at home? Of course we do. And there are people working on this as well, and it's all important. But what does the global divide have to do with us here? Well, I'm not sure who said it. I think it was Tip O'Neill, so that's funny for me to quote Tip O'Neill. All politics are local. So this is a little bit about cancer disparities from the National Cancer Institute. There's a lot of work being done in this area here. Cancer affects all population groups. Some people have higher rates of cancer. Some groups have a higher rate of death from cancer. These disparities are seen frequently in people with low socioeconomic status. Everything we've just been talking about in the global health domain is relevant here. We can also see that some improvements are made, for example, in breast cancer treatment, let's say. But not every community has equal access to those improvements. And so in some ways, the disparities can be increasing depending on the cancer and the community and where they are. Risk factors associated with disparities, according to the National Cancer Institute, include, yes, genetic and biological factors, and you can argue up and down whether that should be called a disparity rather than just a difference, right? There are genetic susceptibilities to various cancers that may be different among different ethnocultural groups, for example, and races. I'll spend a little bit of time talking about breast cancer in this regard. Healthcare access is really the obvious one, right? You have less access, you're going to have worse outcomes. Chemical and physical exposures, I find it interesting. There's a photo on the NCI. This is their infographic of the weed killer, which maybe I'll get in trouble for saying it, but we do know there is good evidence, and IARC has done a lot of work in this area about the carcinogenicity of some of these agents. However, of course, chemical and physical should also refer to tobacco, and alcohol, which many people aren't aware is still, and not still, is a risk factor for a number of cancers, including breast cancer and many others. Diet and physical activity, again, not just a matter of personal responsibility and choice, but nonetheless, these are associated with disparities, however you get there. And the American Cancer Society and their Cancer Action Network affiliate have Cancer Disparities, a chart book, which is very worthwhile looking at. This is, again, online publication. Just to go into this a little bit, examples of cancer disparities include breast cancer. So African American women are nearly twice as likely to be diagnosed with triple-negative breast cancer than are white women, and they're much more likely to die of breast cancer. So what does triple-negative mean? For those non-oncology people in the room, it's a particular subtype of breast cancer that happens. It accounts for maybe 15% of breast cancer in general, if you don't think about ethnicity, but it seems to be overrepresented among African American women and women of African descent, and women in Africa and West Africa in particular. There's a lot of work at the University of Chicago with Dr. Fumi Olopade, and her work in this area has been quite pioneering. Kidney cancer, there's differences. Liver cancer, there's differences. In the communities where people have been brought up in endemic, hepatitis endemic countries, or they haven't been vaccinated for whatever reason, they have much higher rates of liver cancer among American Indian Alaska natives and Asian and Pacific Islanders. Prostate cancer is another cancer that seems to be particularly deadly among African American men. We're still not sure what that's about. Is some of it biological? Is any of it biological? And so I'll go into that in a moment. Cervical cancer, women in rural areas in North America, in the US, are twice as likely to die from cervical cancer as women in urban areas. I mean, that's just really unacceptable. This is a completely preventable death. And it goes on, multiple myeloma, et cetera, which I must admit I don't know enough about. Now, the Centers for Disease Control and Prevention, the CDC, also have really good data sets. You can also interrogate this online yourself and come up with these maps. This happens to be, I thought this was relevant, because here we are, right? I think I got that right. We got the rate of new tobacco-associated cancers by state. Yeah, I looked it up. Make sure I had the right states. Okay. So we see tobacco-associated cancers here being particularly prevalent. Now look what happens when we look at the rate of alcohol-associated cancers. So you may be aware of the tobacco, but perhaps not the alcohol-related cancers. There's a lot of similarity. I'm going to go back to tobacco and then to alcohol. Right. Now I'm going to show you a couple of things about obesity. Not obesity-related cancers, because that data set I don't think is available yet, but it should be soon, because obesity is a major driver of many cancers, including breast cancer. Here we have a map showing the US, and this time the states are named, making my life easier. So here we are. And we see this is self-reported obesity among US adults by state and territory in 2018. The darkest colors show where more than 35% of the population reports as being overweight or obese. And the next highest is 30%. Okay? You're not alone. My country doesn't look much different. We have very different patterns of obesity according to geography, but also our obesity rates are rapidly increasing, particularly among children. I think this might be leveling off in some countries. Now look what we do when we break this down by race. So this is the prevalence of self-reported obesity among non-Hispanic whites by state and territory. And again, here's Virginia. So now we're looking at white Virginians, and here's West Virginia and Kentucky. Look what happens when we change this to Black Americans. Yeah, there's an audible gasp. I had the same reaction. It's seeing the maps sometimes that really hit home, eh? And you can really see what we're talking about here. Now, I'm not going to go into why this is the case. I think there's many people here who are better suited to that than I am. But just to remind ourselves that there are multiplicities of factors here that drive the increased rates of diabetes, cardiovascular disease, and cancer, even here in the US, that are certainly not equal. So according to the Cancer Disparities chart book, despite the fact US death rates have decreased by 26% from cancer between 1991 and 2015, there's been a lot of strides made, not in every cancer, but in many cancers. Not all Americans have benefited equally from these advances, including prevention, early detection, treatment, and even participation in clinical trials, which is something the NCI also pays a lot of attention to. So the underlying causes, or as Sir Michael Marmot, who I'll quote later, the causes of the causes, right, include interrelated factors that are social, economic, cultural, environmental, and also health system factors. And again, coming from a different health system to this one, and I say this one, there are many different health systems in the US, but I happen to live in New York, I see that there are unique challenges, depending on the health system structure and how much of the population has equitable access. This is such great importance to the World Health Organization that IARC actually produced this book this year, Reducing Social Inequalities in Cancer, Evidence and Priorities for Research. Again, this is available online. And look, they have a whole chapter on social inequalities in the cancer burden between Black and white populations in the US. It's not just about developing countries. So let's break it down a bit to some of the cancers that I have a particular interest in, that for which we really do know how to overcome, the entire burden. Cervical cancer, all races and ethnicities. This is the female rate per 100,000 women per year. This is low. We only have 7, something like that, women out of 100,000 developing cervical cancer in this country. That's still double what we consider the goal for elimination, which is 4 per 100,000 cases per year, but it's still pretty low. But look how uneven it is, right? Now look what happens when we look at white versus Black, and here Hispanic women in the US seem to have the highest incidence rates of cervical cancer. And here Black versus white. And now I'm going to change from the incidence to the mortality. Again, we see huge disparities here. So what does this actually mean? And I'm going to, there's a lot of maps, there's a lot of graphs. I want to bring it down to something that's really relatable. It's only about 5,000 women. Only 5,000 women in the US died of cervical cancer in 2018. Okay, that's regardless of race, et cetera, although you now know that most are not white. 5,000 women. Well, that's really small compared to how many women died of breast cancer or how many men died of lung or prostate cancer in this country. Well, what does that actually mean? I say that's 5,000 too many. Roughly equivalent to an entire 747 airplane full of women crashing 10 times a year, nearly 1 every month. What would we do if that was happening? And what would we think if so many of the women who were dying in these plane crashes were from ethnocultural minority groups? Breast cancer is a different story. White and Black, similar. rates, very high rates, highest in the world actually in North America, not just the US, my country as well, have the highest rates. Breast cancer in Vietnam, et cetera, might be closer to 20 women per 100,000 per year. This is upwards of 100. Some of the drivers include reproductive factors, by the way. Breast cancer incidence rates are increasing almost more rapidly than any other cancer due to some of these factors that we can't do much about. How old a girl is when she first gets her period. The earlier the age, the greater the risk of breast cancer. Breastfeeding is a good risk reducer, right? But if you're having fewer children and you're starting your families later, all good markers, by the way, to get families out of poverty, gender equality, kids not being married off, etc., all good things, but they're all drivers of breast cancer risk. That's a sidebar about the epidemiology and why it's important to understand it. Cancer's complex, right? And here we see white and black, almost the same. Black women didn't used to have the same risk of breast cancer as white women in this country, but they've caught up. And here's the survival. There's a huge, huge difference. And some of that may be due to this preponderance of that subtype I mentioned, the triple negative subtype. But this is one I'm not mentioning much about my own research, but I worked with the scientists here, Stephen Narod, who's one of the legendary scientists in BRCA and hereditary cancer, and Javed Iqbal, who's now a scientist in Toronto, originally from Pakistan, who worked with us for a number of years. And we did this study using SEER data. So this is American data. We published in the Journal of the American Medical Association. There's been many similar studies now showing the same thing about the risk of dying of breast cancer if you're African American versus non-Hispanic, white, et cetera, et cetera. In this paper, I want to draw your attention to the fact that death even from stage 1 breast cancer, which is largely curable, 90% chance of surviving your disease with stage 1 breast cancer, 7-year survival was still worse among black women, okay? And when we took away the element of the triple negative subtype, you're probably thinking, well, it's all biological. We took away and reanalyzed without that highly aggressive subtype, and we still saw important differences. So really, we're looking at a complex interplay. And here we have something that is sort of too obvious to mention, but it was very important that the American Society of Clinical Oncology, ASCO's annual meeting this year in Chicago, this past year. There's about 30,000 attendees. It's the largest cancer research meeting of its kind. And we saw in a plenary session, I was so pleased, in a plenary session, something about health systems and how they impact inequalities in cancer survival in this country. And the bottom line was, in states that expanded Medicaid in 2014 or thereafter, the percentage of black patients receiving timely treatment, that was the metric they were looking at, how quickly they got to the right treatment, rose from 6 points. So states that had expanded Medicare had a lower disparity between black and white outcomes. And that was news, okay? But what I noticed was 50%. So what's going on here? Right? This to me was quite shocking, that we're looking at 50% like it was something that was good to aspire to. Which brings me to the great Professor Otis Brawley, who's now at Hopkins, but for many years was the chief medical officer, as I mentioned, of the American Cancer Society. And he produced this, it was actually a blog, and it was published in 2 different fora. His concepts on cancer-critical socioeconomic, not just racial disparities. He's well known for many things, including his work regarding the racial disparities in cancer outcomes in the US. But I thought this was really worth quoting him on. Minding the Gap was the name of this article. And he quotes a study by Kim Rhodes at Stanford that looked at 30,000 patients with colorectal cancer treated in California in an integrated healthcare system and compared outcomes of black and white patients and found black patients treated at integrated health systems received high quality care at higher rates than in other settings. You'd imagine that would be the case. They were more likely to get the right treatments according to the guidelines, et cetera, et cetera. And in fact, their outcomes were the same as for whites. Okay? It wasn't long ago that we thought there was something biological regarding colorectal cancer in African Americans, in black patients. So in absolute numbers, he says, more whites are affected by healthcare disparities than blacks and Hispanics combined. And the percentages are lower, but the number of people affected are much higher. And this is why he said, I've expanded my definition of disparity over the years. I believe healthcare is a human right. Disparity exists when any human being doesn't get the services all humans are entitled to. And in his words, this is not a black race problem. It is a human race problem. The NCI also produced some very important documents looking at poverty, culture, and social injustice in terms of cancer, made some recommendations regarding medical coverage for people who are underinsured or uninsured. Systems for monitoring the treatment equity should be in place, and there's a lot of research now being funded in this area, which is great. Research should be focused on inequities, and of course we have to now account for, in all of our studies and grant proposals, as you know, the gender dimension, the racial dimension, et cetera. But there was one recommendation that I have a little bit of disagreement with, that every individual, regardless of economic status, must share in the responsibility for promoting his or her well-being. Well, of course, I mean, to some degree that's true. But here I'm going to quote Sir Michael Marmot, who wrote a very important chapter in the IARC book of Cancer and Social Inequality. There's a rumor going around, I can't do his accent, there's a rumor going around that poor people are poor because they make poor choices, and that poor people are unhealthy because they make unhealthy choices. The evidence actually points the other way. It's not poor choices that lead to poverty, but poverty that leads to poor choices. And that leads me to the elephant in the room, which I kind of started with by saying that I was Canadian. So universal health coverage has an important role to play here in cancer, in reducing cancer health disparities. And for those of you who don't know, the UN had a high-level meeting at the UN General Assembly this year, September in New York, 2019, had a high-level meeting on universal health coverage. And most countries now are trying to get there. And most countries, many countries, have a plan that they're trying to develop and an implementation strategy to gradually increase not only the amount of health care how much the government's putting into health, which is important. You have to increase the size of the pie, right? Clearly. And in the poorest countries, they're not going to be able to manage cancer. So I don't pretend to say that. They're going to continue to need external development assistance for health, some of which needs to go for cancer control. But for middle-income countries and for high-income countries, to cover more and more of our citizens, right? Not for everything all at once. I was in a country 2 years ago on behalf of the International Atomic Energy Agency. IAEA has IMPACT, which are cancer missions, that they send sort of delegates, representatives nominated by WHO, IARC, and others to cover a particular part of the cancer continuum. I was charged with looking at prevention and early detection in a large middle-income Southeast Asian country. And it was really exciting to see that they were putting their money where their mouth is, universal health coverage. We're going to cover all cancer treatments. Well, in the first year, they practically broke the bank just by one drug. Those of you who treat breast cancer, if anybody's out there, I think you know which drug I'm talking about. So I'm going to say that this has to be done in a careful and considered way. There has to be enough emphasis on prevention and early detection, not just cancer treatments, which we're struggling here to afford, right? So we have to be rational about this. But the declaration, this is joining the dots by the UICC, that's the Union for International Cancer Control, based in Geneva. There's many, many centers in North America that are members of the UICC, and throughout the world, about, I think, more than 1,000 member organizations. And they have formal relations with the World Health Organization and do a lot of joint work in advocacy. They produced this few-page document that's so handy, so good to look at, from the Universal Health Coverage meeting in New York. They said, how does this relate to cancer? Well, first, primary healthcare services, supporting community health workers, building on these previous declarations those of you working in global health will know about. And the language in several paragraphs highlighted the need to connect primary care to other levels of care. And I can tell you, working in New York, sometimes I'm astounded at the fragmentation of the system. So things that you think should be happening aren't always happening. And sometimes, in my view, the onus is too much on the patient to make sure that they get through their own health system, which is complicated at the best of times. Right, I see a lot of people nodding. So the use of patient navigation, for example, and better cooperation between systems, and electronic health records being all more or less the same system, et cetera. And lastly, access to treatment, including diagnostics, vaccines, not just, right, not only medicines, transparency of pricing across the value chain, right? There's a lot of attention now in my world, in clinical, medical oncology, about the value-based assessments of cancer treatments, right? What are we really looking at? Things should be people-centered. Progression-free survival may be meaningless if you have a terrible quality of life. These things are all very important. So we actually know what to do, but how do we get there? So remember that toolbox? First, access to healthcare services, including affordable, local, and systemic treatment that includes radiotherapy, surgery, chemotherapy, and even the targeted agents at lower costs. Policy initiatives to ensure equitable opportunities to avoid the known risk factors. Public and provider awareness of, not just of cancer, but also of cancer health disparities. Uncovering our own unconscious biases as well, making assumptions for our patients without actually asking them what their lives are like and what they need and want. Health promotion to encourage healthful behaviors that are culturally relevant, affordable, and accessible. Ensure that the WHO targets for immunization are met. Health system improvements, cancer screening for the right populations, provided many things are in place to ensure that screening is actually going to be effective in improving population health, and capacity building. Sure, telehealth, mHealth, that happens to be an area of my research as well, to reach the hard to reach in terms of their geography. So I'll end on a hopeful note here. With a focus on cervical cancer, the former UN Secretary General Ban Ki-moon called for cervical cancer being eliminated. He lit the fire a little bit, or lit the match, and then WHO took it over, took it on, and the current Director General announced that all countries should take action to help eliminate cervical cancer as a public health concern at the World Health Assembly in 2018. There's now tons of research and efforts going into this cause, being more or less coordinated through the WHO with many partners, including in academia in the US. But Australia is going to be the first one to eliminate the disease. They started earlier with universal vaccination of girls and boys, and also they already had a strong system to encourage and cover most women with cervical screening and treatment of precancers. But guess which is the second country on track to achieve this? Maybe Canada? Who says Canada? Brazil. Pardon? Brazil. Brazil? Oh, that's a good guess. It's Rwanda. It's Rwanda. I spoke to a room of high commissioners and health attachés at the Commonwealth last week in London about cervical cancer with some colleagues, including a former Nigerian Minister of Health. And I mentioned this, and the Rwandan High Commissioner was there. She was so proud. Yeah, it was covered on BBC that day. I didn't know, so they knew already. All right. And I'll end with this statement by former director of IARC, Dr. Chris Wilde. Cancer is a universal illustration of inequality between human beings in terms of the risk of developing the disease, timely diagnosis, access to treatment and care, knowledge, the chance to experience a life beyond cancer, and even hope. Thank you for your attention.
Thanks, that was fantastic. I'm sure there'll be many questions, so let's start with the front row.
Didn't leave much time.
Thank you for a comprehensive and very encouraging message. You've made clear the multiplicity of events that can lead to these disparities. Mm-hmm. One of the challenges, I think, is to communicate this more complex view so that people have the option of considering combining various approaches, whether it's at the individual level, the systems level, the country level, and given your insight into this with comparative analyses from around the world, what strategies are you thinking about in terms of making this very complex message actionable to different segments of the population in this global health perspective that you laid out? And I know that's a very broad question, but in addition to the scientific advancement, it appears to me that there's a great need to communicate this story that you've told so well in ways that allow people who are not used to thinking of 6 and 8 and 10 factors simultaneously affecting outcomes to better appreciate that and to take action?
Well, thanks for an excellent question, which is a challenging question. I think what you've touched upon here is the difficulties that we as scientists sometimes have in making, relevant, short, take-home messages that we can actually walk away with and take action on. I would suggest that, broadly speaking, not to take too much time with this question, but I think it's an important one, that efforts to help support countries, particularly in need, who are asking for this kind of technical advice in national cancer planning is one such opportunity. So this is maybe this is a too academic an answer, but when we look at national cancer plans, some countries now submit to a community that I am involved in called the International Cancer Control Partnership, including NCI, WHO, and all the other agencies I mentioned. And they ask us, how can we turn this into something we can use? Well, the first thing we look at is, what are your priorities? And let's help you with priority setting. Because like I mentioned, in the country in Southeast Asia where I spent some time to try to assist in the government work, they'd put all their money in one thing, which was treatment. And in fact, putting all your money in just prevention is one such option. And the countries that are the poorest, we actually recommend, look at prevention, primary prevention policy initiatives, because those don't necessarily cost much at all. There's lots of good cost-effectiveness data even on that. And palliative care, because everything else in the middle is going to have to wait. And in other countries, we talk about what are the key things you want to do in the next 1, 2, and 5 years, and that's going to include advocacy efforts, educating the public and providers, policy work, and also vaccinations. Get that part done, and then you look at the health system level issues and see if there's something, efficiencies can be made through strengthening of referral mechanisms, that sort of thing, which I often say the health system part is the least sexy but arguably the most important thing that we can do to improve cancer outcomes. And then palliative care, having access to morphine in particular. There's this huge disparity in access here. We have too much in some places and really not enough in most of the rest of the world. So I think you can take which message you want from that and run with it depending on what your interests, area of expertise, et cetera. But we have to communicate this in a much simpler way, absolutely. And I would go to the UICC website because they do this beautifully, also including with infographics.
Sure, if I can, I just want to follow up a little bit on Craig's on the communication message. It seems to me the issue, I'll just use one simple word, trust, might be important. You and I talked a little about this, but if you deal with the elephant in the room and have universal access, you still have to have people take advantage of the access. So Warren Bickel's work aside, where are you, Warren? There you go. Separate from individuals not valuing the future in their own health, just put that aside for a minute. But people's belief in the system, whether it's their trust or distrust of science or bureaucrats or the health system, how do you get by that as well?
Another excellent question, and I had the pleasure of meeting with Professor Bickel earlier to talk about concepts regarding choice as well as other things. Well, I would say that there's a lot of good work being done by people like Electra Pasquet, who I think will be possibly speaking here in the near future. Her work is focused in Appalachia from Ohio State University, looking at those very issues regarding trust of the healthcare system, in addition to all of the other complex factors that prevent these improvements being translated to the folks who are living in these regions. That really brings in the issue of, or the importance of, medical anthropology. And I'm really learning now, at this late stage, how important it is to have access to the knowledge base and the perspectives of anthropologists in this regard. When you're dealing with populations who've traditionally been either left out or frankly abused by whatever communities were in power at the time, however long ago, those effects are lasting. And that is something that needs to be addressed not by oncologists and not by epidemiologists necessarily, but perhaps by community engagement with people who are community leaders, talking to, participatory research, community-based participatory research is a real strategy that's so critical to help overcome these historical wrongs and improves trust in the system.
Sure.
For a while, I did work in Alaska with a number of groups of Indians and Eskimos and Native Alaskans on 3 topics simultaneously, all involving women. One was excess maternal deaths. They were having 6 to 7 babies when we were having 2 in the lower 48. Fetal alcohol syndrome, especially in young alcoholic women, and mothers not stimulating their babies. And all of these people tried to be culturally sensitive, taking efficacious interventions, but there was a common denominator that the lower 48 and we scientists brought. We think choice and disease and death is all inside a person. And up there, not everyone thinks of their body as their own. So we had people giving birth control to women who were given options and picked it, and then there was a huge excess in emergency room admissions of women beaten by men who hadn't been consulted about that choice. And the same with women stopping drinking and women talking to the babies when everyone thought you were mentally ill if you talked to a baby because the baby. So the idea of putting the burden on people who've already been marginalized and live in extreme stress with inadequate resources, that we really need to not only do the ethnography, the anthropology, but engage, as you say, participatory. We went to junior high and high school students. They had the best ideas about how to reach brothers and sisters and aunts and uncles and parents that there wasn't an academic in the room that would have thought of. So we have to be, I love the way you started with this being open-minded, but we really in the US and maybe a number of other Western countries think our body is our own and that person, herself or himself, should seek care and do prevention and do treatment. And sometimes it's a collective choice.
Absolutely. That is such a good point. And I just, in my own research in Canada with the South Asian communities, I was working in Bangladesh, and then, I recognized there were some issues that might be worth exploring among the Bangladeshi Canadians, many of whom had been in the country for many years. They had healthcare access. They tended to be more affluent, actually, healthier, the healthy immigrant phenomenon, right? More affluent than the women that we were interviewing in rural Bangladesh. So even with all of those factors, what is important to them? What would be useful for this community to help increase their participation? In this case, it was breast and cervical cancer screening. And actually, there were several South Asian communities, Hindi, Urdu, and Bengali-speaking groups. We did a concept mapping exercise, one of these sort of mixed methods research efforts, and we learned exactly that not just, we talk at WHO about the whole of government approach, right, multi-sectoral approach. They taught us about the whole of family approach. And this is it. The collectivism is really something that's was unfamiliar to many of us, but so familiar to probably most people in the world. Don't have such an individualistic framing that we do. And that translated into pragmatic solutions. The bus to help the women who, they didn't have a problem with transportation per se, but they wanted to go together. They also wanted to include their husbands or their fathers in the discussions, to destigmatize breast health as an issue, et cetera, and also help them feel included. So some groups are also adding on discussions around prostate cancer so the men aren't left out. But even, having the daughters talk to the mothers and the intergenerational aspects, all important. Yeah.
We actually observe those kind of things that you mentioned here in the rural area of Virginia. The need for educating the caregiver, what is going to be the caregiver of the women with breast cancer. Also, very many occasions we run into men with breast cancer that they are ashamed of actually tell, their folks around that they actually, it's a very low percentage, of course, but the knowledge about the existence of breast cancer in men is kind of a taboo thing, and in the rural areas in particular seems to be even exacerbated. It's like they're really afraid of communicate that. and they prefer not to actually, follow up with any treatment. I was really amazed in my interaction with women's work that, that experience breast cancer and everything in this area, how poorly educated they were about the topic of breast cancer. At the beginning, it was something more like, well, if I'm diagnosed, I won't be able to pay for the treatment. And we provide those women with options, what options you have. And then it was more about the partner not wanting the women to actually go and get a screening.
Yeah.
So there's a lot of education that we still need to do around, because in some places it's still a little taboo thing.
Absolutely. And in fact, I often say, we have these discussions in low and middle income countries, and people think in certain cultures breast cancer is taboo. It's like, how could it be taboo? It was taboo here until, recently, and still is in some communities, of course. Breast cancer wasn't something you spoke about at the dinner table when I grew up, which wasn't that long ago. But in fact, women's troubles, women's cancer. So in taking cancer family histories, which is what we do, of course, in the genetics program that I work in, it's something that you don't have to go too far back to see that it's really hard to get that kind of information. But so education, destigmatization, and understanding the cultural values as well as what might drive certain myths. We used to say about the women in our clinic, I think I mentioned it in the talk, that if you've never met anyone who's survived this disease, of course you're going to think it's a death sentence. And why would you spend what little money you have to go to the hospital to die when you should be spending it? The government's telling you to spend it on your children's school books and uniforms.
That's usually the speech that we get.
Yeah.
Please join me in thanking Dr. Ginsburg.
Thank you. Thanks very much.
Very good.